So we are very happy to invite to the stage one of the leaders in our field, Dr. Bill O'Neill from Henry Ford, to talk to us about AMI shock, outcomes of SCAI Stage E. Bill.
Thank you very much for allowing me to come back to this wonderful Congress, and this is a fantastic thing you guys have created here. I was at the first course, and I think it maybe a couple hundred people, and now you have 2,000, so obviously you're doing something right, and the something right started yesterday with the patient focus, and those patients up here was just so impactful, and I think that's really what drives everybody to be here away from their families and their practices to really try to learn how to do things better. So I really want to congratulate the group, and I'd love to come back, and we've got some interesting studies that we can show you next year. So starting in 2016, after Impella was approved, Barbara Brasier and I organized the National Cardiogenic Shock Initiative. We've talked about this study here before. There are 400 patients. 400 patients were enrolled in 80 sites, academic and community hospitals. And the results, and unfortunately the colors don't show, but the top two lines were the survival rates for patients in the National Cardiogenic Shock Initiative, 77% survival for patients that are in class C and D, and 68% overall for the entire group. Compared to the original shock trials, and now you put the dangerous trial somewhere in between. And the problem with talking about the National Cardiogenic Shock Initiative is that it's a registry. And we've been doing studies for many, many years, and it's been very difficult to randomize patients in cardiogenic shock in the United States, largely because of the informed consent issue. And it's been very difficult, and I've come to the conclusion, at least in the research that I'm going to be doing, is going to be prospective, well-done registries, which can be very useful when you have mortality as a marker. I think that registries can be done very useful. But the biggest problem with registries is case selection. If you select only near-dead patients in one registry and only mild shock in another, the results can be very different, and it's unrelated to anything that you do during the cases but case selection. So we now have looked at this post-approval study with Impella. It was done again between 2016 and 2020. There were 400 acute MI patients that were treated in 41 referral centers throughout the United States. And the thing that was quite interesting was that 72% of the patients were in Class E shock. In the danger trial, there's about 30%. In NCSI, there are about 30% of the patients who are Class E. So these are the sickest of the sick. And it did give us an opportunity to look very carefully at these patients to see what the outcome was. Again, so if you compare NCSI to RECOVER-3, the NCSI results look better. But a large part of that is just case selection, because we had what I think is probably in most large registries, about a third of the patients are going to be in Class E. But here, because of center selection, and these were referral centers where the sickest of the sick were being referred, we had a large group of patients that were in stage C. That slide doesn't work. So this now looks at all the trials that have been done recently, and to the far right is the RECOVER-3. In the purple is the number of patients that are in Class E shock. In the middle, you can see the Hansen study. That was the National Cardiogenic Shock Initiative. Those are the two trials that had the largest groups of patients that were in Class E shock. And if you take a look at other trials, in the middle, Janssen, there's hardly any patients in Class E. The vast majority of patients are B and C. So you can't compare these trials very, very well without really knowing the shock stages. And I think that's one of the important things that we're going to be doing looking forward in terms of the outcome of these patients. If you take a look then at the results of the survival for these patients, you can see that the mortality is extremely high with mechanical support based on Class E stages. On the right, you can see the results for our RECOVER-3 trial and a very high mortality, but the other studies really showed a much higher mortality. So if we're going to make any further progress, I think that we're going to have to make progress on all, but the one group that is really important is the Class E patients, and I think if we're going to do anything to dramatically improve the survival more, it's going to have to be concentrating on these patients. These patients are very dynamic, and again, in the RECOVER-3 study, if we looked at the patients that came in with shock and what their stages were, it's a dynamic process with many of the patients going out of Class E and then going into C and D. However, there are are patients that started in C and dropped to E by 24 hours, and this is a dynamic process that impacts survival. In fact, in the patients that did not respond, in the Class E patients that remained in Class E at 24 hours, their survival was only 30%. So I think that what this is telling us is that there's a lot of action that's going on early on, and we have to follow these patients carefully, because if you're in Class C and drop to E, that patient is dying. And so that's if we're going to intervene, it's going to be early. What happens to the patients 3 or 4 days out is almost irrelevant. It's going to be related to secondary complications, but if we're going to really improve outcomes, we have to carefully watch these patients over the first 24 hours. In the OASIS trial that is now being started here in the United States, we're going to monitor these patients at every 6 hours and look very carefully to see at the stages. And if the patients seem to be deteriorating, then we're going to have a very low threshold to escalate. Simply put, we think that the algorithm is going to be E equal escalate, because I think a 3-5 device probably for the Class E patients is not going to be adequate. If we look at the outcome for these patients, at 30-day survival in RECOVER-3, on the left is the survival for patients that started with Class E, B, C, or E shock, and on the right is at 24 hours. So actually the survival curves are much more splayed at 24 hours. So I would really urge when you're treating these patients, it's not just how they present, but how they respond that is very important. And if they're not responding, if there are multiple pressors, low blood pressure, low CPO, then I think you want to have a very low threshold to transfer these patients to a surgical unit to get the Impella placed. The predictors of who's going to respond, I think, are really interesting. If putting in the Impella before seems to improve the likelihood of responding, and the number of vasopressors that the patients are on. So high doses of vasopressors during Impella predicts that they're not going to respond. And also, interestingly, the use of greater numbers of lesions treated. So the patients that responded seem to have more complete revascularization. And then escalating inotropes are harmful, and baseline white blood cell is harmful. So I just want to conclude for you that 50% of the patients in E improved to C or D within the first 24 hours. Those are the responders. The responders had a significantly improved survival compared to non-responders, 56% versus 28%. The predictors of response were mostly related to treatment strategy and not baseline clinical characteristics. And then SCAI class is not only a baseline, but again at 24 hours of Impella may provide more meaningful prognostic information. Thank you very much.
Thank you, Bill.
Thank you very much, Bill. I was just curious, I think timing of unloading prior to reperfusion might be important. Did you look at that and see what happened?
We are doing an analysis of that, and actually Barbara Basir is looking at a very extensive combined database looking at door to support in a very finite method, and it does look as though the earlier you support the patients, the better the outcome. We're going to try to do something similar to the 90-minute door to balloon time. We're going to come up with a number that is going to drive, but I think that what we as a health system have to do is to try to get these patients identified and supported as soon as possible. I think that's going to improve outcomes.
It would appear that if you can unload prior to reperfusion, you're probably going to have a better long-term outcome, I would
Yes,
think.
yes.
Dr. O'Neill, thank you for all the work that you've done and set the stage. It's an honor to be up here with you and ask a question. It's a technical question for stage E. If I recollect correct, E has 2 phenotypes, and one of the limitations of the classification is if you have a cardiac arrest, you automatically become E,
Right.
versus the metabolic profile that drives it. Do you know if in all these studies we distinguished those 2 cohorts, or they were all lumped?
No, we don't. They were lumped, and in the data that we did, they were lumped.
Okay. And do you think as we move forward, we should look at those profiles for escalation? Because it's a disadvantage, right, if you put somebody in just because of out-of-hospital arrest and the metabolic profile gets better.
I've wondered about that a lot, because if a patient has CPR, for instance, for 15 minutes and they've got multivessel disease, then the heart is going to be stunned and they're going to be in shock. And supporting them may actually be better, and it may not be like the true class E shock, where they have a massive anterolateral infarction with a previous old right coronary infarct, and they're basically just in extremis. And so I think those are two different categories, but you can be a splitter or a lumper. I've never been a splitter. I like to be a lumper. And so I think that it's just for simplicity's sake, it's worthwhile. But in the background, I think actually the patients that have had CPR and are neurologically intact actually are going to do quite a bit better.
Please.
Thank you for the talk, great talk. Wanted to ask about the NCSI registry for patients being transferred from non-registry centers to registry centers. Are those patients counted in the registry? And for example, if someone comes in after PCI and the balloon pump, you upgrade to an Impella at your institution, how are these patients counted and looked at?
Yeah, we excluded the patients that had previous balloon pump, because when we started looking at this in the CVAD registry, we found that there was a practice pattern that evolved where one group of patients had a balloon pump placed, and then if they failed balloon pumps, they were transferred for support. So basically they're balloon pump failures, and so they've got a long time before they actually get supported, whereas the Impella First strategy, in the Impella First strategy had better outcomes. So we actually didn't look at those patients in NCSI.
Bill, thank you again for your work in this field. So along the lines of what Arvin asked about the stage E patients that they are in arrest, and we just talked about the arrest trial, the checks also replicated some of these results. What's your comment about the utilization of stage E, that phenotype of ECMO?
The one simple message I would have about out-of-hospital arrest is that if the patients have signs of anoxic brain injury and are in shock, they have a terrible prognosis. And putting an Impella in is of no use. Those patients, perhaps with a neuroprotective strategy, might be of value. But again, in the CVAD registry, we looked at 51 patients that came in with anoxic brain injury and shock, treated with Impella, and they had a 90% mortality. So I think we have to look at a different strategy for those patients. They usually end up with neurologic death, and Impella doesn't help with that.
Mm-hmm. And if I may just ask or add, I feel that when we're talking about these arrest patients or stage E patients, really the thing that might make the biggest impact is not something cardiovascular at all, but is about the prognostication within the first 24 hours of neurological outcomes. Because we were also talking about the out-of-hospital cardiac arrest and the moral injury of people taking care of these patients, having to take them off ECMO, the administrative costs and realities of it. If we really got to that point where within 24 hours the neurology testing could tell us where we are on the neuroprognostication, and we could stop appropriately or continue if it was there, I think that would be such a game changer.
Yeah, and just again, a brief comment about that is that I think that we have an incredible palliative care service, inpatient palliative care service, which are phenomenal. And I've been with families and said, okay, there's no hope, and let's make them comfortable. And it's not that hard to do if you really work with the families. Although there are some like incredibly difficult families, I totally agree with that come in once a week or phone in from out of state and do everything. But most families, I think, are very reasonable. They don't want their families to be prolonged, and the getting those people rapidly within the first 24 hours, I think, is really important. Getting them on board if you know that they're not doing well because they're likely not to do well. Thank you.
Thank you, Bill.